Hi, my name is Lourenço and I'm a master's student at the University of Lisbon and King's College London. Today I'll be talking about SEGANet segmentation for CINE MRI to automatically estimate the left atrial ejection fraction. This is a summary with all the topics that are going to be described during this presentation. So I'm going to start with the motivation for this project, then I'm going to describe the methods starting with data acquisition, and then I'm going to describe the SEGANet structure. Finally, I'm going to discuss the automatic SEGANet segmentations, and I'm going to talk about the data analysis taken from these segmentations where ejection fractions were calculated. The impact of AF. Atrial fibrillation is the most common cardiac arrhythmia, which is characterized by rapid and irregular contraction of the atria, as you can see in the figure, and it can be detected using a SEG, as you can also see. AF affects more than 33 million people worldwide, and although is mainly managed with medical therapy, catheter ablation is one of the gold standard treatments to terminate AF. However, in the current form, ablations are only first-time effective in 50% of the AF patients. But how can we increase the treatment efficiency for AF? So, catheter ablation efficiency could be greatly increased if specific biomarkers were available. For example, the LA dimensions have been shown to be good predictors for post-ablation patient outcome, and it is expected that dynamic characterization of atrial dimensions and volumes across the cardiac cycle, they maybe even be more informative. And in particular, the LA ejection fraction and active ejection fraction, they contain important clinical information that can contribute to manage AF. At the one hand, the LAEF characterizes the global function of the LA across the cardiac cycle. And at the other hand, the AF characterizes the pump function, which is likely to provide important additional clues about the atrial tissue health. But how can we estimate LAEF and AF? So standard techniques, they use 2D CINE MRI and empirical formulae where an expertise chooses a slice and the time where the LA volume is maximum, minimum, and in pre-A, which is where the LA volume is at the onset of atrial contraction. So in these slices, it's possible to calculate the volume using L, as described in this equation, has the longest atrial length. And with the volume estimations, it's possible to calculate AF and AAF. However, these techniques have some disadvantages, such as they do not sample the full atrial volume. They also provide an approximation of the LA volume, which means that AF and AAF are going to be also an estimation. In particular, AAF is really challenging and is usually not provided. Finally, this process is time-consuming and depends heavily on the user experience. Due to all the reasons described before, our project aimed to automatically measure the LAEF and AAF from 3D CINE MRI short-axis images using a neural network to segment the data, named SEGANet. But why 3D images? 3D short-axis CINE MRI images, they combine good spatial and temporal resolution. So the volume estimation from these 3D images is expected to be more precise. In Figure 1, we have an example from our dataset. In Figure 1a, we have a representative slice with the ventricle structures in short axis. And if in the Figure 1c, we have also a representative slice in short axis with the atria structures. In Figure B, we have a pseudo-tooth chamber comprising the atria and the ventricles, and the locations from the slices A and C is also represented in Figure 1b. Regarding data acquisition, we use the 1.5 Tesla Philips engineer scanner with a 32-channel cardiac coil to image 60 AF patients and 12 healthy volunteers. All the images are in short axis with full cardiac coverage. All the images have also a slight thickness of 10 mm, and due to this large number, it is difficult to identify the separation between the atria and the ventricles. In order to solve this challenge, we used a pre-trained left ventricle segmentation network to identify the slices containing the ventricle tissue, and with this information find the slices with only atria. SEGANet is a network that has a stack of 4 layers which combines the encode and the decode path, as you can see in figure 4. The proposed method is based on a UNet architecture but with modifications, such as residual units, which prevents vanishing gradients, instance layer normalization, which minimizes the influence of outlier images, and prelude activation functions, which allows the network to learn from negative values. In order to prevent overfitting, data augmentation functions were applied during the training process, which comprises functions such as stochastic noise, k-space corruption, smooth non-region deformations, and intensity scalings. SEGANet was trained during 5,000 iterations and with a training dataset of 750 slices. After the training process, in order to measure the segmentation quality, measures such as dice coefficients, mean counter distance, and Hausdorff distance, they were estimated relative to the ground truth and manual addition segmentations. Finally, the LAEF and AAF, they were calculated for both AF patients and healthy subjects from these segmentations. SEGANet's LA segmentations show good quality results, as you can see in figure 5, where you have automatic segmentations obtained with SEGANet for one representative subject doing atrial diastole and overlaid with CINE. In figure 5a, we have the short axis view. In figure 5b, we have the pseudo two-chamber view, and in figure 5c, we have the pseudo four-chamber views. The method has some advantages, which are comparative simplicity and lower parameter numbers when compared with other networks. The fact of treating each slice independently and with an extensive data augmentation strategy, the network was trained with few number of patients. And finally, this segmentation uniquely includes the LA appendage, which is relevant for assessing the stroke risk in AF. The quality for SEGANet segmentations can also be seen on figure 6, where we have the box plot for dice coefficients on A, the Hausdorff distance on B, and the mean counter distance on C. In all the images, we are comparing SEGANet segmentations, firstly with the manual the ground truth, M1, and the additional manual segmentations, M2. In figure D, we have the counters indicating the results with the manual and automatic LA segmentations in one representative slice. In yellow, we have the SEGANet automatic segmentation. In red, we have the manual M2 segmentation, the additional segmentations. And in green, we have the ground truth segmentations. By doing the mean for the older metrics, we can also see that SEGANet performs high-quality atrial segmentations, being on pair with other neural networks and with manual segmentations. In data analysis, we had calculated the volume across the cardiac cycle, and as you can see in figure 7, the LA volume varies smoothly, as expected. The values for LAEF and AAF, they are in accordance with the literature, and in figure 8, as expected, we can see a variability in AF patients and healthy subjects for both LAEF and AAF. In conclusion, SEGANet shows a good performance for the segmentation and allows the automatically estimation of LAEF and AAF. In the future work, we will build a deep characterization of the LA function for the prediction of the outcomes in AF, Thank you for your attention.